Good morning and welcome back. Hopefully you guys had a very nice weekend, had a chance to relax and, just take it easy and get ready for a mechanical vent. Last video that we did, we talked a little bit about the ABG. Remember, when we're looking at ventilatory or hypercapnic respiratory failure, we have to look at the ABG to determine what type of ventilatory or respiratory failure do we have. Is it something that's acute? Acute means it happened in a very short period of time. Or is it acute on chronic? The acute still means the same thing, but the patient lives in hypercapnic or ventilatory respiratory failure. These are your patients who have emphysema, COPD, patients who have neuromuscular disorders, whatever happens to work with them. If you look at their ABGs, you're going to notice that their pH is like 7.39 at the top. If it hits 7.40 for these patients, then we have a mixed problem that's going on with them. When we're talking about hypercapnic or ventilatory respiratory failure, when we look at our ABG, remember your ABG is always an uncompensated respiratory acidosis. Most folks want to, when they look at the bicarb and see it elevated, they want to say, okay, it has to be partially compensated. The thing you need to remember, this is an acute condition. Because it's an acute condition, your bicarb is not going to be able to respond for at least 24 to 48, even up to 72 hours, depending on how bad the CO2 is, what's going on with these patients. So when we're looking at these ABGs, we want to make sure that people understand that these ABGs are not partially compensated, that bicarb does not belong to that ABG. Remember, in order to determine acute hypercapnic respiratory failure, once we go ahead and we have our blood gas, we're going to go ahead and start with a pH of 7.40, and we're going to start with a PaCO2 of 40 millimeters of mercury. An acute hypercapnic respiratory failure, every time that pH decreases by 0.08, your PaCO2 will increase by 10 millimeters of mercury. A quick and easy way of doing this is take a look at quick and easy way of doing this is look at your pH of 7.0. If you do 7.40 minus 7.0, there's a 40 difference. If you divide the 40 by 8, there's a 50 difference. 50 plus 40 is 90. So if your pH is 7.00, your PaCO2 is 90 millimeters of mercury. That is an acute hypercapnic respiratory failure gas. In acute on chronic hypercapnic or ventilatory respiratory failure, pH doesn't move as slow, it moves really quite fast. If every time the pH decreases by 0.03, your CO2 will increase by 10 millimeters of mercury at that point. And that's because these patients live in chronic respiratory failure with elevated CO2s. So again, the Insider's Guide to ABGs. Whenever that pH is normal, the ABG is normal. Don't let somebody talk you out of this. If your pH is 7.35, that's a normal pH. That ABG is normal. This is what we're trying to normalize. We need to get that pH within that normal range. And once we do that, it will take care of the CO2 for us. It may take your CO2 a couple of days, maybe a little bit longer in some cases to come back in range, but as long as that pH is within the normal range, we shouldn't have a problem with our patients. You always don't need the bicarb. Remember, I told you people will look at ABGs and tell you the bicarb is elevated. Because the bicarb is elevated at this particular point in time, then it has to be a partially compensated respiratory acidosis. We know that's not true because this is an acute condition, happened within the last 24 hours at least at this particular point in time, so there's no way that bicarb has been able to go ahead and respond. Any PaCO2 greater than 120 millimeters of mercury is unreliable. Our ABG machines are not able to figure out what it is. How do you know that your patient has a PaCO2 greater than 120? you'll see a lot of times it'll come up in the blood gas slip will show you 120, may even show you 130 or something like that. If you look at a lot of these patients, they're still looking at you. They may not be able to carry a conversation on with you, but they can nod their heads and shake their heads and they know yes and no. In chronic respiratory failure, the pH when compensated will not reach your 7.40 unless there's a mixed problem, okay? What's happening then is the bicarb and the CO2 are both competing to get that pH where they want it to go at that point. And so what they're doing is they pull the pH back into that 7.40. The last one, too, bicarb will not respond when the PaCO2 is greater than 85 millimeters of mercury. You look at your ABG, your bicarb is 92 millimeters of mercury. That is still an uncompensated respiratory acidosis. And the reason is your PaCO2 is greater than 85. Okay, so there's a couple of ABG sheets I'm going to go ahead and put onto Blackboard and have you guys go ahead and do interpretations with them. Part of the interpretation is going to be whether the patient is in respiratory failure. If so, what the type or types of respiratory failure for that patient. The other thing is, remember, there's two parts to an ABG. There's the acid-base balance, and then there's the oxygenation. All of the ABGs have to have an acid-base balance and an oxygenation with it. So questions come up, why do we ventilate? What are the indications for putting a patient on a ventilator? Remember, with our patients who have COPD, one of the things we want to do is try to keep them off the ventilators. We're using the high-flow nasal cannulas now. We're also using BiPAP, CPAP on occasions, not as much as we used to because of the high-flow nasal cannulas. I was reading an article the other day that talked a little bit about the high-flow nasal cannulas. Two different articles, two different viewpoints. One of them basically said that, if you have hypoxemic respiratory failure, that you probably could use the high-flow nasal cannula. The other article said, yes, you probably could do that. However, it's a nice stopping point before you have to ventilate that patient. And so sometimes it's in between putting them on the high-flow nasal cannula and then going to intubate them at that point. So there's a lot of controversy still out there. As a result of that, we're going to continue to look at it and try to figure out what is the best way to handle these patients. The clinical indications for ventilation, one is impending respiratory failure. You're not there, but you're going to be there. And what we're trying to do is we're trying to stop it if we can, or at least give you a break and put you on a ventilator and let you relax. Sometimes we can also do this with our CPAP, BiPAP machines. Acute respiratory failure, you've passed that point. Now it's time to support you and to support your cardiovascular health also. Severe hypoxemia, we're going to talk about that. Apnea. Apnea is one of those things that we look at. I've had a lot of the graduates come back. They talk to us and go, the question asked, why do we ventilate? And apnea was on there, and we didn't want to choose it, but it was part of the answers. Well, if your patient is apneic and they're going to be apneic more than 10 seconds, you got to start taking a look at them a little bit closer. If you've got a patient who's apneic for 20-25 seconds, they're not doing very well at all, and they're going to need some type of support at that particular point. Another one we see on occasions is prophylactic ventilatory support. Not everybody includes this, and that's not a problem. Why do we do this? Think about sometimes, and you're going to see a few more definitions when we get to the slide further on. If you have a patient who has to go to the MRI or the CT scanner, you tell the patient this is what we're going to do, which is going to give you some drugs to sort of take the edge off. Then we're going to put you in this closed container. And some of these patients are claustrophobic and they're not going to be able to handle it. And so in order to be able to get the information we need, we'll go ahead and intubate them, give them medications to knock them out, do the test that we need to. Once we're finished with the test, we can reverse the medication, extubate them, and then things will work out for our patient at that particular point. Question comes up, well, if you notice, there aren't any metabolic conditions in any of the slides we talked about. The only thing we talked about were lung issues or problems with the pump, the vascular system at that particular point. So the question then comes up, why aren't there any indications for metabolic conditions? And really the reason for this is ventilators cannot be used to solve metabolic problems. When we ventilate our patients, we're ventilating them for respiratory problems. Now, folks will say, well, then, why do we worry about metabolic problems? Well, if you remember that a patient who has a metabolic alkalosis, the compensatory mechanism is a respiratory acidosis. And if you remember with the respiratory acidosis, think back to that time, you remember that's an elevated CO2. It's going to be higher than 45 millimeters of mercury. How does your patient get to that point? Fairly easily. They're not breathing. So if your patient is not breathing, things are not going to be going well with their body. Things aren't going to be going well with them. So what we're going to do is we will go ahead and ventilate those patients, keep them on the ventilators until we resolve the underlying problem, which is the metabolic problem that's going to be taken care of with the doctor and what they're going to do about it to take care of this patient. But we don't ventilate the patient because they have a metabolic problem. It is the respiratory portion of it that we're ventilating these patients. So basically, what is impending respiratory failure? Basically, what's happening with this is the patient is breathing. Their breathing is beginning to slow down. They may have been breathing like 32, 34 times a minute. They're starting to get tired. And as they're starting to get tired, their ABG still looks fairly normal, but we start to notice that the pH is in fact going down and the CO2 is beginning to go up at that point. And so as a result of that, they're going to have some problems with end organ dysfunction, vasoconstriction and shunting, and acidotic cellular necrosis going on. So what we see in respiratory muscle fatigue in these cases, the elevated PaCO2 with a decrease of pH, progressive decline towards a pH less than 7.3 and a CO2 greater than 50. Hypoxemia, acidosis, and then that major stress again on the cardiopulmonary system, where we see again that vasoconstriction, shunting, and then cellular necrosis occurring at that point. Acute ventilatory failure, a little bit different in this case. It's a primary indication for mechanical ventilation. You have a rapid increase of that CO2 to 50 or 55 millimeters of mercury, a rapid decrease to less than 7.30. You may see apnea, or you may see severe cyanosis at this particular point. If you have a hypoxic patient with a normal or decreased PaCO2, in this case, you may be able to use the high-flow nasal cannula or even CPAP, BiPAP at that particular point in time. So it's just a matter of what's going on with these patients, what's the underlying cause at this particular point, and how can we handle this. This is one of those indications that you want to think about if you have a patient who comes in with CHF. At that particular point in time, what they need is alveolar recruitment. They also need to make sure that we can move that fluid out. And so sometimes if we can put them on a ventilator or even CPAP or BiPAP, we may be able to go ahead and take care of them without having to ventilate them. Severe hypoxemia, we use this mechanical ventilation to meet the body's oxygen needs. Great big demands being put on there. The thing that you guys remember, there's only a very small part of the oxygen that we inhale and use for the heart. The majority of it is for the brain. Your brain is very, very selfish. It's going to try to get all the oxygen it can to stay where it can and be able to function as best it can. However, as we start to get more and more into hypoxemic respiratory failure, we start to see the CNN system misfunctioning at this particular point. Definition of severe hypoxemia. Interesting. A PaO2 less than 60 millimeters of mercury on anything that is equal to or greater than 50% FiO2. If you remember, mild hypoxemia is anything greater than 60 to 79 millimeters of mercury. Moderate hypoxemia starts at less than 60, but here's an extension of that definition: less than 60 millimeters of mercury on an FiO2 that's equal to or greater than 50 FiO2, or a PaO2 less than 40 millimeters of mercury on any FiO2. So if you have a patient who's on 100% oxygen, you have them and you do an ABG, their PaO2 is 38, they have severe hypoxemia, and we need to go ahead and try to determine, what's going to happen to them to be able to reverse this, okay? Some of the indications for this: burns, carbon monoxide poisoning, pulmonary edema, ARDS, all about those different things that are going on with this patient. There's no gas exchange going on, or limited, actually, gas exchange going on at this particular point. And as a result of that, we're not getting the oxygen to the body as much as we need to. Apnea, like I said, apnea is one of those ones that people go, I don't know why we have to ventilate them. Apnea, we can use CPAP or BiPAP, take care of it. People at home have apnea and they're on this equipment. And all of that is very, very true. But we're talking about a patient who's apneic for other reasons. They don't have sleep apnea, okay? So here's what you need to remember. If your patient is not breathing for several minutes, all is not right in the world. And if you cannot reverse this condition with Narcan or other reversal agents, you may have a really interesting problem that you're going to have to take care of. So apnea is an indicator for some type of support. The prophylactic ventilatory support, as I said, a lot of times people don't have used this at all. What we're trying to do is prevent hypoxic and acidotic effects on the organ system. Some of the pulmonary complications we see with this would include smoke inhalation. If you guys remember from emergency care, we talked about patients who were in fires. When they come into the hospital at this particular point in time, we need to assess them, whether or not they have an inhalation injury. And if they do, then sometimes we have to go ahead and intubate them to protect the airway and not lose it once we start giving them fluid. Other reasons: head injury, prolonged shock is another one. This patient's not coming out of it. We need to make sure that that airway is being protected also. So the things that we need to watch for, we want to go ahead and preserve that cardiopulmonary system as best we can. We don't want to cause more of a shunt or anything else that's going on there. We want to decrease the risk of pulmonary complications, ventilatory failure and O2 failure. These would be, some of these are patients or people that are undergoing surgery, be it thoracic or abdominal surgery. Any other surgery where the patient is not awakened from them, then we are probably going to leave them on ventilators. It is not unusual that people who take patients who take drugs for pain are sometimes very hard to sedate for surgery. In those cases, coming out of it, because we give them so many drugs, they don't wake up the way they need to, and then we can run into problems with them. Interesting story, I got a call one time. They wanted an ABG on this patient. He had surgery. Physician goes, I'm not sure why he's not waking up, but I need you guys to go ahead and do an ABG on him. Let's see where his status is. We went ahead and did the ABG. He didn't flinch. His ABG didn't look terribly bad. Looked pretty good, as a matter of fact. And Doc says, well, just leave him there and we'll address it later. Probably within about a half an hour, 45 minutes, we hear this alarm going off in one of the rooms. The nurse and I are looking, trying to figure out which room it is. Every time we would get close to the room where this patient was, the alarms would stop. And so this went on for at least a good 10, 15 minutes. Finally, the alarm went on and it didn't stop. And we went into the room, and here's the patient sitting up in bed holding the ET tube going, I can't breathe with this in my mouth and down my throat. And we're going, oh, okay. We went ahead and put him on some oxygen, called the physician. Physician said, just leave him alone. I know he's doing really well. His sats were really, really good, and he had no problems at that particular point. So it's always interesting to see what's going to happen with these patients. The other thing it does for us, it does decrease that work of breathing. Remember, and this is one of the things we always have a tendency of forgetting, whenever your patient has a high or an increased work of breathing, they're using a lot of oxygen. When you're using a lot more oxygen than you're actually taking in, especially if it's not going to cross across the alveolar capillary membrane, then unfortunately the body is going to suffer. And when the body suffers, there we see that necrosis that happens as an end result of all of that. So then the question says, what do we do for ventilatory support? One of the things you want to think about, and you'll see this when you're working, especially in the acute care facilities, is you have to have it in mind as to what do you want the outcome of what this support to be. And what I mean by that is you just don't go up to a patient and go, I haven't intubated for about 6 months. I'm losing my skills. Do you mind if I practice on you? Most patients have a tendency to turn you down. So we want to make sure that when we're intubating a patient, we want to do it because there's a real problem that exists, that we know what the problems on the body are going to be at that particular point, and that we need to work to resolve them to make this patient better. So we have to have in mind a goal. And the goal is what are we going to do to make sure that this problem is either going to be resolved favorably on the patient for the patient, or perhaps the goal may be is to keep this patient with us until some loved ones arrive or other family members arrive, or that the patient in fact is ready to leave. So there it is, your goal: support the patient until the underlying problem is resolved, support the patient with chronic ventilatory problems, help them go ahead and relax their muscles. Remember, we talked about loading and unloading the muscles. With someone who has chronic ventilatory problems and they're using a lot of accessory muscles, we need to unload that work of breathing. We do that by providing ventilatory support. Once they're getting better at that particular point in time, then we can reload that work of breathing on their muscles, and then we can go ahead and extubate these patients and liberate them at that particular point. One thing to remember, although you set a goal for a patient, that goal can change. You always want to be evaluating those patients. How do we achieve this? We improve alveolar ventilation. Remember, alveolar ventilation and PaCO2 are opposite of each other. As one goes up, the other has to go down. And so what we want to do is we want to bring that PaCO2 down, and we want to provide better ventilation for that patient. We want to improve the arterial oxygenation. Remember, we just did a definition of severe oxygenation, PaO2 less than 60 millimeters of mercury on any FiO2 50% or greater, or any PaO2 less than 40, regardless of what the O2 is at that point. We want to increase the lung volume so that they can breathe better, and we also want to reduce their work of breathing. Do we know by looking at a patient, are they going to be on the vent for a long period of time, or are they going to be on the vent for a shorter period of time? We really don't know until we actually start taking care of that patient. We had a gentleman one time, we came into work, they said, you guys need to go down to the ED. There's a patient who suffered anaphylaxis, and they went into status, okay? So we go down there, we do the ABG, the patient's pH was 7.06, that we were suctioning out some shrimp and potatoes and other things out of his airway. By the way, he was allergic to shrimp, but he ate it anyways. We went ahead and put him on the ventilator at that particular point in time. Everybody was thinking he's going to be on here for a while because of the anaphylaxis. This was, like I said, around 6:30 in the morning. At noontime, we had him extubated. So we were able to reverse that problem fairly quickly as a result of that, and he didn't have to be on the vent for a longer period of time. So there are some numbers, and these numbers come out of Egan's. They're on page 998, and they will differ a little bit from chapter to chapter, but these are numbers that you need to know. These are numbers, as you look at them, that talk about the mechanism, the norms for them, and then when is support needed. So that sometimes the book shows you different things as far as this goes. With this one, if we look at the numbers, you have inadequate alveolar ventilation, okay? Remember, with inadequate alveolar ventilation, you have that increased PaCO2. So remember, the normal PaCO2 is 35 to 45 millimeters of mercury. Support needed in this case is anything greater than 55 millimeters of mercury. We know that at the beginning of the chapter, 44, it said if your patient was on room air and the PaCO2 was greater than 50, they were in respiratory failure, which is an indicator for some type of support. So this time we're going to change it a little bit, and we're going to go ahead and use 55. The pH, remember, is normal, 7.35 to 7.45. Support needed anytime less than 7.20. When you go to the hospitals, one of the things you want to ask is, what are your numbers that tell you that you have an adequate alveolar ventilation and that this patient is going to need support? When you have those numbers, these are called your critical values. That's what tells you that you have to call that physician and tell the physician what's going on at that particular point in time. When you do this, one of the things you have to do is when you do call that physician, you have to document that you called them. You have to put the time, the date, all of that good stuff on there. Just don't sit there and go, well, you know, everybody knows, blah, blah, blah. No, not everybody knows. You have to make sure that you go ahead and document these numbers and who you talked to and where you left the information. Inadequate lung expansion, for the most part, your tidal volume. Tidal volumes are 5 to 8 mLs per kilo, okay? We're not using ideal body weight in pounds anymore. We're now using the ideal body weight in kilos. What this basically means is this. Mr. Jones comes in. Mr. Jones is about 5'6". So as I mentioned, the tidal volume, 5 to 8 mLs per kilo. Anything less than 5 mLs per kilo is an indicator for support. So what I want you to do is take out a piece of paper. You have a male who is 5 feet 6 inches tall, and you want to find out how many kilos is he. So remember your formula, 106 plus 6 times, in this case 66 minus 60, is basically 106 plus 6 times 6, which is 36, and 106 plus 36 is 142 pounds, okay? We're going to take that 142 and divide it by the 2.2. Divided by 2.2, you come up with 64.5 kilos, okay? I'm going to use that as a nice round center point for this one. What I want to know then, what is his tidal volume range? So what you're going to do is take that 64.5, multiply it by 5, and then you're going to take that 64.5 and multiply it by 8. So go ahead and do that. Okay. So if you've done that, then your tidal volume range is 322.5 mLs to 516 mLs. And you can round it to 323 mLs to 516 mLs. If his tidal volume that you measured is only 300 mLs, 300 is less than 323, he then is a candidate for support. Okay? If you measure his tidal volume and it comes only to 300 mLs, his range starts at 323 mLs. He is now a candidate for support. In order to start weaning him, his tidal volume has to be greater than 323. Okay? Remember, less than 5 will put you on support. Greater than 5 will take you off that support. Okay? Everybody good with that? For the vital capacity, if you notice, it's also in mLs per kilo, and it's 65 to 75 mLs per kilo. If we take this same patient who is 64.5 kilos and multiply by 65 mLs per kilo and 75 mLs per kilo, we're going to come up with a range of 4.2 to 4.8 liters, okay? Much easier to report this in liters at this particular point. Remember, the last name for this, just like the last name for tidal volume, is going to be mLs. The kilos actually cross out. Or in the case of vital capacity, it could also be liters, okay? Vital capacity is one of those unusual ones that we see. And part of the reason it's unusual is you're going to drop all the way down to less than 10 mLs per kilo, technically, to say whether or not you need support. Most of the time, we're going to be a little bit suspicious before you ever hit that value. So how do I get that less than 10 mLs per kilo? I'm going to look at his weight. His weight is 64.5 kilos. I'm going to multiply by 10. If his vital capacity is less than 645 mLs, he is a candidate for support. Okay? So you have to come all the way down to 10 mLs per kilo, less than 10 mLs per kilo. And once you do that, he now is a candidate for support. Respiratory rate, normal 12 to 20. Anything greater than 35 is considered a need for support. Anything less than 35 is an indicator to go ahead and start weaning. Do not be surprised when you're in the hospital and working that they don't use 35. A lot of times they use 30. And until this edition of Egan's came out, it had always been 30. Okay? So it's just one of those things that we need just to be aware of. So then we're also going to look at inadequate muscle strength. And what we're going to talk about is your MIP-NIF. And remember, this is measured in centimeters of water pressure. When you're doing these, you remember when you were doing them in cardiopulmonary diagnostics, you didn't do them just once except for the MVV. You did them 3 times. And when we do weaning, we also do them 3 times because we want to make sure we're getting the best from those patients. Do we do them 3 times to find out whether or not you're doing well? Sometimes you can, sometimes unfortunately you can't. The normal NIF-MIF is -80 to -100 centimeters of water pressure, okay? Support required is anything greater or equal to -20 centimeters of water pressure. These are negative numbers, and because they're negative numbers, you're going up on that scale. So if the patient's MIF-NIF was -18, that is an indicator for support. And if you notice at the bottom, it says within 20 seconds. So this is not one of those things that you go into and go, okay, let's do this really quick. Yeah, that was okay as far as that goes. That's really, really bad too. You have to coach these patients, and you're going to do them for greater than within 20 seconds at this particular point in time, okay? Hospitals have their own requirements. Some of your hospitals will tell you -20 is way too low. We want to know before then. At one time, the folks who were at Banner were telling us theirs was either -25 or -30. That's hospital specific. For purposes of the course and the books, it's anything greater or less than equal to -20 rather at that particular point. And again, inadequate muscle strength, we look at the vital capacity, same value, 65 to 75 mLs per kilo. Anything less than 10 mLs per kilo is an indicator for support. MVV, if you can see, it's liters per minute. Normal's 120 to 180. Anything less than 2 times the minute ventilation is an indicator for support. Most times, if you have a patient who's been breathing 30, 32 times a minute, and now they're beginning to slow their breathing down because they're starting to tire out, if you ask them to go ahead and do an MVV, you're probably going to see them coding on you. So if you're going to have to do this, you need to make sure that your physician is with you. When you go to get your equipment, come on back and bring your vent back with you. Bring your ET tube tray back with you. Plant it outside the room. If the physician goes, "What are you doing?" And you can tell them, "We're just waiting for them to code. We want you to be able to intubate them." Do you have intubation privileges at the hospital? Because if you don't, you need to go get somebody, because that's exactly what's going to happen. One of my mentors, I was talking with him one time, and we were sort of joking about this a little bit. And he said, "Yeah, we did it one time, and the guy promptly coded on us, and had to be intubated at that particular point in time." So the MVV is something, if you can really avoid it, that's one of the things you want to do. Increased work of breathing, there's your minute ventilation. Anything less than 10 liters per minute. The chapter has 5 to 6 liters per minute. We use anything greater than 10 liters per minute is basically what you're looking at. Your VDVT, and this is your dead space based on the modified Bohr equation, and we're going to talk about that. It's a percentage. Normal is 0.25 to 0.4. If you think about it, 1/3 of your normal tidal volume is dead space. That 0.33 fits in beautifully right between that 0.25 and that 0.40. Support required if your dead space is greater than 0.60. Okay, so if you have a lot of dead space, there's not a lot happening in the way of perfusion at this particular point in time. You have a lot of wasted ventilation. So anytime your dead space is greater than 0.60, this is something you want to think about at this point, okay, because it is a requirement for support. For hypoxemia, something we've talked a little bit about already, the P big A minus little AO2, the gradient, millimeters of mercury on 100% oxygen. Remember, the norm is 25 to 65 millimeters of mercury. Anything greater than 350 millimeters of mercury is an indicator for support. To come off of the support, anything less than 350 millimeters of mercury on 100% oxygen is what you need. And then remember your PaO2 to FiO2 or your P to F. Norm is anywhere between 350 to 450. Anything less than 200 at this particular point in time is an indicator for support, okay? And one of the things you want to remember, these numbers don't tell us, is this patient going to be a long-term patient? Is this patient going to be a short-term patient? Does this patient have a rapidly reversible condition, like the gentleman who was in status asthmaticus? He turned around in less than 4 hours, was off the ventilator, or is this something that's going to turn into a long-term condition? Your physicians are, a lot of times, really good physicians are really good at telling you this patient is going to be out for 2 or 3 days. do whatever you need to at this particular point. We should see about the third or fourth day, they should begin waking up and responding to us much better than they are. And when that happens, a lot of times these guys are now eligible to go ahead and be weaned at that point. So that works out really well for them. So, little review. It's always nice to review. Elevated CO2 is the result of, number one, your respiratory center not responding to those increasing CO2 levels or increasing O2 levels. Because remember, our patients who live with chronic respiratory failure are not breathing off of their CO2, they're breathing off of their O2 at this particular point in time. So if the message is sitting there, but the message can't get out, because remember the medulla oblongata and the pons is where we go ahead and send those messages out, then that patient is going to have the elevated CO2. Respiratory center responds. However, when the message gets sent out, it's not reaching the respiratory muscles. Respiratory muscle failure or fatigue, a neuromuscular disease. There's no way that it's going to be picked up, the message is going to be picked up by the muscles at this particular point. The third one is the message was recognized, the message was sent out, it went to the muscles, but the problem is there's a very limited response because of either muscle lung disease or muscle weakness, increased work of breathing. The body's not able to handle at that particular point in time. Major causes of hypoxemic respiratory failure. Remember your shunt, your VQ mismatch, alveolar hypoventilation. Remember, with all of these, the PaO2 is decreased. The PaCO2 can be normal or decreased in a shunt or a VQ mismatch. It's always going to be elevated with alveolar hypoventilation. You're replacing that PaO2 with the PaCO2, and so that's why the CO2 will be much more elevated. Also remember, with a shunt or a VQ mismatch, we have an increased A to A gradient, and we have that because we're adding oxygen. That doesn't mean, though, that that added oxygen in the alveoli is going to be able to diffuse across the AC membrane, and so as a result of that, that gradient gets larger and larger. In alveolar hypoventilation, the gradient remains normal, and that's because, like I said, the CO2 is being replaced by that CO2, and as a result of it, the gradient stays basically the same. And so the question then comes up, how do we choose? Does this patient need to be intubated? Can this patient use the high flow nasal cannula? Can this patient use CPAP BiPAP? What's going on with these patients, okay? A lot of it depends on what does the patient look like and what's going on with these patients for sure, okay? So the question is, if you want to paraphrase Shakespeare, do we intubate or not to intubate? And remember, a rose is a rose, and a rose is a rose by any other name. And in this case, an ET tube is an ET tube, and it's an ET tube, and it goes by any other name. So do we want to do that, or do we want to do something else? Is the condition rapidly reversible? Yes, maybe. No, for sure. We really don't know until we get this patient somewhat stabilized, figure out what's going on with them. Let's take a look at the x-rays. If we need to, we can do a bronch, figure out what's going on with the lungs. We can do scans if we need to. Let's take a look at this patient, try to determine what's going on with them at this particular point in time. And then a big one that also applies to your CPAP BiPAP, can this patient manage their secretions and protect their airways? If your patient cannot protect their airway, if your patient cannot manage their secretion, they are not a candidate for CPAP BiPAP. They're not a candidate for high flow nasal cannulas. They are a candidate for mechanical ventilation because that ET tube is going to be able to protect their airway until they're able to do so themselves. This is something I'm sure that Teresa talked about quite a bit in critical care. We need to make sure that we understand that. Now, one of the ways you can decide whether or not this patient is going to be able to protect their airway, if your patient does not have a gag reflex, they're not going to be able to protect their airway. You're going to have to do something to go ahead and protect it for them. So we need to be able to evaluate these patients and then make recommendations based on what we see, and then make sure that we understand what has to happen at this particular point in time. We have to have that goal that we're going to set. If we put you on a ventilator, what are we hoping to be able to do to get you off of this support? If we're going to put you on the ventilator, when do we stop that support if we know we're not going anywhere as far as that goes? Okay, so that's one of the things that we always have to keep in mind.